Did you know you can watch this whole video for free at OnlineMedEd.org? Oh, serious question. Did you know that?
This is shock 3, septic shock. It's also where we discuss sepsis. Sepsis 3 guidelines, QSOFA and SOFA, aren't great. SOFA and QSOFA are good because if you're lazy and don't want to practice medicine very well, you can sit on your couch and type in some numbers and generate mortality. The problem with the couches is that you have to first suspect an infection in order to use them, and they give no help in defining what that means. It was good in the sense that it said the SIRS criteria are not the things you should use to determine to give antibiotics or not, which is true. It also said the early goal-directed therapy we were doing is stupid, and it is because people are just trying to meet the numbers. I'm going to give you in this lesson my approach to handling SIRS and sepsis. It is not meant to contend with guidelines and literature. It is not meant for a textbook. It is meant for you, the intern, to be armed with information and reasoning behind it for you to make a decision on a patient right there in front of you. Sepsis 2 wasn't right. Sepsis 3 isn't right. We're working our way there. But most importantly, you need to know what you need to do with a patient in front of you. So this is how I handle things. And it makes a lot of sense to me, and hopefully makes a lot of sense to you. All right, let's start off with the SIRS criteria. Yes, you should still think of these. They're based on the temperature, the heart rate, the respiratory rate, and the white blood cell count. Each of these is worth 1. Temperature greater than 38°C or less than 36. Heart rate greater than 90, respiratory rate greater than 20, white count greater than 12 or less than 4. Let's talk about limitations of these first. You can be infected and be SIRS negative. You can be SIRS positive and not be infected. Every time you go to the gym, you are SIRS positive because your heart rate and respiratory rate go up. The SIRS criteria are useful because when you get to the vital signs, you can immediately decide if they're inflamed or not. It doesn't mean you're right. This is not the only thing you're going to use, but it makes sense to me to walk into a room, look at the monitor and say inflamed or not inflamed. Look at the computer before you walk in the room. Based on the vital signs, are they inflamed, not inflamed? It's one data point. If they are SIRS positive, perk up your ear, you should look harder. An immunocompetent patient that doesn't have an elevated temperature and doesn't have a leukocytosis is probably not infected. Every time you go to the gym, you don't get antibiotics and blood cultures. Just because there is a fever doesn't mean they're infected. See our approach to fever video, the fever house. What I'm trying to say is that this is one data point, a screening tool. If they do screen positive, pay attention. The other thing is that now we are getting to see more patients with advanced disease, HIV, AIDS, cancer, and immunosuppression for a lot of diseases that we used to have no treatment for. The aging population may not be able to mount an inflammatory response, so you may be SIRS negative and still positive for infection, especially decompensated cirrhotics. Check out cirrhosis. Those patients present with an elevation in their MELD, and that's their SIRS. So you see, there are many limitations to using this. But the amount of time it took me to explain this, I could have done this exercise for 100 patients, SIRS, no SIRS. And in fact, when I do morning report, I always stop at the vitals and make one of the interns in the audience answer SIRS, no SIRS. The next question is infected or not infected. In an immunocompetent, there's no fever. They're likely to be not infected. But this is a good screening tool to say, hey, they might be infected. You should take a look. So these are the SIRS criteria, right? Let's talk about grading the severity of sepsis. And I'll talk about the new information and limitations thereof. So the SIRS criteria You need 2 of 4 to be SIRS positive. In order to be considered septic, you have SIRS with a source. Severe sepsis is sepsis and. This is a modification of the Rivers study. We used a lactic acid of greater than 4 and a systolic blood pressure less than 90. We've gotten more sophisticated than that. It's sepsis plus either an elevated lactic acid that is greater than or equal to 2 or a low blood pressure. And since we're in the ICU, we're using MAPS. MAP less than 65. Septic shock is severe sepsis that is unresponsive to fluids. And if they're unresponsive to fluids, they get vasopressors. Septic shock goes to the ICU. Severe sepsis, which is responsive to fluids, goes to the floor. This has the greatest utility for you, the intern. The SOFA score says, severe sepsis is more than just lactic acid and mean arterial pressure. There could be other signs of end organ damage. Yes. The problem with that, though, is that people do the fluid challenge and they check a lactic acid because a lactate clears if there's no more shock.
You should probably go to OnlineMedEd.org now and watch the rest of this video.